think, oh wait, hold on.
Yeah, and just lots going on, but I feel badly that a lot of this work has just been on hold, but we've just been so focused on COVID, and so many
Yeah.
of our programs have been, Lynn, Lawrence, like communities that have been, Chelsea, have been so impacted by COVID that that's been so much of our focus.
Yeah.
Um,
Yeah. Well, you got
but
to do what you got to do. We'll
I
make
know.
sure, Carol, that we have your information really well highlighted. And then, Allie, after we can make sure it gets sent back out to the Wave 2 teams as
Yeah.
well.
Yeah, that
Hmm.
sounds good.
Yeah. And feel free, I don't know how, if you share these slides or not, but feel free to share the slides with the participants or
Thanks.
post it on your website or whatever you want to do. There's nothing on there that's confidential or can't be shared. So,
We do. We post these as PDF.
yep, good.
Another thing, Carol, I know that you sometimes join the POP meetings
Yep.
as well. If there's any specific documents you'd like to be, we're creating a resource folder to give to all the participants who go to the summit. It's going to be accessible online. If there's any specific documents you'd like to have in that resource folder, definitely you can email them to me. I'll follow up with
Okay.
you after this, and I can include
All
them
right,
in there.
great.
I think the links that are on here to documents, I think could definitely go in a folder. There's federal poverty guidelines. There's the one pager on what is early Head Start. There's a new screening tool. So any of those, Ally, that have live links on the slide could go
Yeah.
in as resources, I think.
Okay, great. I'll definitely make sure to include
Yeah.
those. Thank
And
you.
Is this till 1 o'clock? Okay.
Yes. Ron, do you want to wait for a couple? I don't know how many people usually join, when you'd like to start, or if you want to wait for a couple other people.
Yeah. I mean, we oftentimes are around 14 or 15.
Mm-hmm.
But on the other hand, there's a clock over there in my corner ticking, you can see. And usually around 12:03, 12:04 we start. So
Yeah.
Okay.
Do you want to start recording and we'll get it going?
Yep, sounds good.
Awesome. Thank you.
Thanks, Allie.
Okay. Welcome. We are here. Can you go back one slide, please? At the actually final webinar for Pinquin's AIM OUD and Pregnancy series. We've been through one wave with a number of hospitals, 19, and now we're finishing our second wave. So wanted to welcome you here today. I'm Ron Iverson. I'm a general OBGYN. I'm going to host this, and we're going to go through who else is on the webinar today in just a bit. If you could please just chat in who you are, where you're from, so everybody knows who else is on the call with us. We love these collaborative meetings, and we're going to try to provide some space for people to share what they've been doing. Thanks, Linda. Next slide, please. And so the general plan today is that we are going to say hi. Allie, can you just come on and say hi? This is Allie Doyle.
Hello, everyone. It's nice to meet you all. I've emailed with a couple of you previously. I'm on the neonatal side of Pinquin, so mostly working on the perinatal opioid project and filling in for Kaylee this week.
Yeah, Kaylee's awesome other half. And I have to say, we were talking before, Kaylee set us up real nicely with this slide set. So thank you to Kaylee. She's sorry she couldn't be here to say hello and goodbye to this webinar. She's done such a good job over the last year on this, couple years. Next, please. So the usual webinar housekeeping. This is sort of cute and old now because we've all gotten pretty good at webinars, I like to think. So just please, though, this is a collaborative space. If you want to chat in, I'm going to try to keep watching the chat box for comments. And so Allie will, we're happy to stop and talk about whatever's important. Next, please. So this is our Wave 2 teams. It's a great group. I think there's been a lot of actual improvement and movement in these sites. And we're always excited to hear what you guys are doing. Next, please. This is the larger team of the Penguin Perinatal Opioid Project team leadership. And you can see we've got neonatal folks, we've got maternal teams, we have people from academic and state spaces. We actually have had wonderful family involvement in both our planning and as well as our summits. Next, please. Just a few event announcements. Really, really key is if you are taking the time to do this, then you're really going to want to come to the virtual summit. And that's on June 15th and 16th in the afternoon. We've been working hard. Kudos to Ali and everyone who have done such a good job preparing 2 days of excellent summit material. The first day, we're going to be focused more on the mother or the birth parent, looking first with some family voice with Kelly Kidd. Dr. Pooja Mehta will speak a bit about SBIRT and linkage and disparities in care. We'll then have a conversation with a panel including Letitia Goulard, Kelly Kidd, and Amy Walker on what happens when you actually have a screening process that identifies someone who is open to help. How do we engage? And the next conversation is about cannabis and pregnancy, what to do. We have talked about having this panel for a few years now. We're finally going to do it. So this will be really very interesting with the experience and the policy and plans at a couple sites, and trying to extend that conversation to see how that's appropriate for your site as well. On the 16th, we're talking more about the whole family, and we're going to start with thinking about the father's perspective for a family affected by opiate use disorder. We will have a speaker or speakers for that. Dr. Stephen Chapman from up north in Vermont will be speaking on the plan of safe care. And then we're going to have 2 excellent panels talking about plan of safe care and some pathways that are being developed. And then also the opioid epidemic and how it affects our families. And Dr. Sarah Stulak from the BMC SOFAR Clinic will be coming on to talk. Next. So we also have other things that Penguin is working on. We have a great process for learning about stigma, bias, and trauma-informed care. This was developed at the Brigham Women's Hospital. It's an online course. You can take it and get CMEs. Also, we have the Speak Up Champions implicit and explicit bias training. This is available online for free, thanks to our state partners who are funding that. And then also for folks who've been through that, who want to become ambassadors and help teach these courses on implicit and explicit bias, that will be coming up on July 15th. Next, please. So I forgot to mention that today we are joined by others to speak after we talk about the QI webinar topic. We're going to talk about a Healthy Start and Head Start, and that's going to come right after this. But first, you have to listen to the QI webinar topic, which is sustainability. People always stress out about sustainability because it feels kind of intangible and kind of a pain in the neck to have to continue to watch what you're doing. But it's so key. And I have to say that in my work in quality improvement for substance use disorder, work that we do is really, as well as everything we do, this is really where the money is for actually improving a system and having it stay on track for a long time, is thinking about sustainability. Next, please. That's me, Ron Iverson. And this is, I love this slide because it really puts the idea of sustainability, front and center for us. We do all this work on the top with PDSA cycles and getting our systems up and going. We improve our design, we set policies, but really, we need to keep an eye on things, quality control. We continue to need to measure it and watch it, and then maybe make small adjustments within that space. Or sometimes we actually have to start a new project to get things going again. We just found out that within our hemorrhage bundle, one of the things that I thought was working great when we were doing some measurement on that, people aren't doing as frequently as we thought in terms of, in this case, oxytocin in the second stage of labor, third stage of labor, excuse me. And it was only by actually doing a little bit of measurement on that and seeing how often it was being done that we figured out, goodness, while we thought that this had been built into our practice, it's even in our order sets and our policies, it's not happening. So that probably is going to get to escalate problem and some more change ideas to get that put back into shape for us. So, I could give you tons of examples of times where I thought that things had been built in and were running, but really need to be watched to make sure we're providing excellent care. Next, please. So the first step, though, for getting sustainment to actually happen in your system is to PDSA everything. Every step in the process that you're working on should be tested to make sure that not only do people believe that it's important, but that you have the tools and the processes set up so that it'll actually be able to be done. There's nothing more frustrating for folks than to be asked or told to do something and you don't have the tools to do it. So basically, PDSA everything, make sure that people can do the work and build the system so that it works for the people who are doing the jobs. Measure to know that you're getting the change you want. And that's hard. You can build reports to do that. You can actually ask people, and that's an easy way. And if you find that, 2 out of 10 of the people say, well, I don't really think that's working, then you might want to even do another type of measurement if you don't have a report about it. But make sure you ask people what's actually happening. In your chart reviews, when you're reviewing events, you can also find it that way. Remove other options. Take away orders that don't actually do what should be happening, and make it so that the order sets are easy to work with. Build policies and guidelines based on what you've learned. So we always say this in PinQuin work is don't build a policy until you know that it actually works. And remember that whole PDSA cycle for every part of it. Then actually, once you've got it, then you can build your policy. Next, please. So how do we know when we've done enough cycles? How do we know when things are going to work? Well, you can measure again that each component is functioning and do some double checks to make sure that everything's actually lined up after you get to the end of the bundle to make sure all your parts are working, that they set people up for the next stage, that they all mesh together well. Ask people, has this become the daily work? Remember that culture is really what happens when people who are in leadership aren't there around to make sure it happens. So make sure that the culture has changed. Make sure your daily work is what you think it is, and it's doing the process that you expect. Make sure that that your resources are always there. People will change what they do if you don't give them the tools to do it. We're so good as humans to find workarounds and new ways to do stuff. If we don't have what we need, be that tools, technologies, orders, whatever. So make sure that people have what they need. And then finally, when you do debriefs and other larger reviews of what's going on, particularly when there's a problem or when you have a great success, make sure that the team actually reports this happened consistently in their debriefs and other reviews. Next, please. So how do we do sustainment? So now you've built a system that you think is actually going to hold the process that you've been working so hard on. So set that plan for measurement. We have learned to, when we have our EPIC folks with us early in a project, ask them to start building the report. Our most recent success was it took us about 6 months to rebuild our hemorrhage evaluation tool. And as we built it, I asked them to build a report so we can measure whether it's doing what we want it to do. And so it happened almost at the same time that when the tool was built and placed into Epic, that we could get reports on it. So you think early on those reports. So whenever you do see that a change is detected, don't just blow it off. Look at it, see what happened, see what's new in the process. Is there new technology, new people, new ideas? Going back to that third stage of labor and giving Pitocin topic, there had been some new providers who came into our system who didn't actually know some of the newer data that suggested that that's the way to do it. So we, that was part of our process, is going back and doing some education. So be ready to incorporate the new tools and ideas. New stuff comes onto the field all the time. Make sure that gets built into your system so that folks can have a nice easy glide through taking care of people. And most of all, show people their success. It is, I agree, more exciting to show a line that's going up and your improvement. But for a lot of us, it's also nice to see a nice line that's stable, that shows excellent work being done over time. And those slides are really powerful, and they provide the why. They're particularly useful, again, when new folks are coming into your space, and we want them to understand this is how we do things, and this is why. Next, please. So that's sustainability. There's a fair amount to say about it. There's a lot of work that goes into making it happen. And I'm always interested in feedback on your sustainability successes and failures. If you want to talk about that, but we like to provide a space right now for teams to just give any other updates they have on what they're doing. And I know that the Beverly team is here. Teresa, welcome. And so why don't we start with your updates, and thank you so much for these slides and for what you've been doing. So back in the collaborative spirit, let's see what you did, and maybe others can gain from it. Thanks, Teresa. Are you able to come off mute? Let's see. Okay, well, I'm not hearing Teresa. Teresa, if you're able to get off mute, we'd love to hear what you have to say.
Ron, can you hear me? This is Shanna.
Oh, hey, how are you? Yeah, that's great. Do you want to go through these slides on what you guys have been doing at Beverly?
So I will do my very, very best, and I am hoping that Teresa is able to unmute herself at some point, because I'm going to sort of stand in for her and the incredible work that she did. So I'm not quite the best person to present this to you, because she did all the back work along with Dr. Sherman of the Moms Do Care program here, the Compass program at Beverly Hospital. But I will do my very best, what we have done, why we did it, and sort of what the outcome has been. Do we have an ability to move the slide forward, Teresa? There we go. And this is actually the first time that I've actually seen these slides, Ron, so I'll be completely honest with you. We started off with Dr. Sherman, Dr. Melissa Sherman, created a breastfeeding attitude survey for our providers, both nursing staff, physicians, obstetricians, and pediatricians, to determine their level of comfort or knowledge in caring for mothers with either a history of substance use disorder, those that are in recovery or not yet in recovery, and how they manage to care for these families with a trauma-informed approach, while upholding the mother's desire to breastfeed and hope to breastfeed, while balancing the medications that they're on, either medicated or certainly not like unprescribed medications. So this is that first slide that back in the late fall, November, December, the provider attitude survey went out. And it was really just to garner the providers, pediatricians and obstetricians comfort in not allowing, but signing off and recommending and supporting mothers in their desire to breastfeed if they were had poly substance management for their substance use. So we attained that. And then with that, those results, sort of, I think, Teresa, you can chime in the chat if you want to, correct me if I'm wrong, while they were accessing all of those surveys, Teresa created, along with Dr. Sherman, sort of like a stoplight system tool. So it's green light, yellow light, and red light. And I bet it's going to come up here in one of the slides, but essentially it is like a large, even larger than an 11 by 14 page that we've laminated. It is a little bit small, but it's a there we are. It's pretty big, but it's incredibly thorough, and it's 2 pages. So all of the medications, any and all medications that Dr. Sherman knows about potentially the patients would see, and she's highly experienced and engaged with this population, they're noted here on the left. And anything that's in green are medications that are safe and acceptable to use for breastfeeding. And included in that is the resource, the reference for it. Any medications that are in yellow essentially mean that a discussion, a conversation needs to be had if mom is choosing to breastfeed, and that maybe a little bit more extra monitoring for the newborn to ensure that he's not or she's not too drowsy or whatnot, or not impacting the baby too much, but definitely a conversation with the providers. And then I believe there is only one out of dozens and dozens of prescribed medications for the mothers to treat their anxiety, depression, their substance use disorder, you know, their insomnia, their bipolar, the whole gamut of the symptoms that come from their traumas to help them in their recovery. So Teresa, I'm not sure if we're able to see just the one medication, but essentially, Ron, what this tool has done, it has allowed not just the obstetricians and the pediatricians the ability to look at this tool and sort of sign off on that this mother is safe to breastfeed given the medications that she's prescribed, but it has enabled the nursing staff as well as the lactation consultants to be able to review the medications and see that the obstetrician or pediatrician has seen the patient's medications and has signed off that they are safe to use. Because what we were seeing was Dr. Sherman say prenatally has told mom that the medications, whether it's like buprenorphine and Klonopin together, yes, those are safe to use for breastfeeding. You'll be able to use for breastfeeding. And then when she delivers here, her pediatrician may say, no, I don't recommend breastfeeding. And then the nurse may say something else. So by rolling out and implementing this tool, we have given us the ability to provide the patients with consistent messaging in their postnatal experience. And what we've also created is part of our, because we're on the baby friendly journey, is a newborn feeding plan. It's also an 8x10 laminated colored document that's in each room in 3 languages, and it's laminated so it's clean between each use, but it talks about problem solvings and interventions for the mother while she's here at the hospital. But at the very top of that, we added to it, we edited it once this tool was finished, the breastfeeding medication, are my medications safe to safe for breastfeeding? And it's a yes or a no. And that answer doesn't change. And so for usually the 5-day eat, sleep, console time that they're in the hospital, that's either a yes or it's a no, and it doesn't change.
Yeah.
So Trace, I'm not sure if there's another slide just to show what else we've done here with that. So the survey results.
A lot of nurses.
A lot of nurses. And so it's sort of follow-up survey.
I think, just to cut in, I think that, because I read these slides, they're really good. I think you're still mid response. So this is 34 on the follow-up,
Right.
and the baseline, I think, at 117. So
Right.
I'm sure you're going to get more responses too.
Yes, so we are still seeking post-implementation of the tool responses and how that has impacted their care and approach, and the outcomes for the mothers, ultimately seeing whether our exclusivity rate increases predominantly for this population. So yes, we are still obtaining the responses from providers. So more to come on that.
That's great. And so, and this is the sort of partial results. So it's so interesting. 97% of the follow-up responders had reviewed that reference tool. That's amazing. And they'd found, good job to Dr. Sherman and all of you guys for making something that people found useful. And it even influenced practice 53%, it says. That's spectacular. This is such a great process measure.
I agree. And it's not just something that guides their practice. It's allowing, not just the physicians, but the nursing staff as well, to have confidence in the direction that we're giving the patients, that I think it's safe. I mean, it's probably fine, versus being, I'm confident this is the direction based on these references from LACTMed or AAP. And so it's not only increased their professional stance and their professional knowledge, but has obviously had an impact on our patients as well, because they feel confident that the pediatrician is saying yes or no, the obstetrician is saying the same answer, and the nursing staff is saying the same answer. So we're not getting this constant, I'm getting mixed reviews and mixed recommendations, which we had been seeing quite a bit. So
yeah. Well, I really appreciate you coming on and giving that presentation. Let's see, and thank you, especially since you hadn't even seen the slides. That's spectacular.
I was winging it. I probably did a very, very poor job, but
yeah, you totally knew what you're talking about. That's awesome. Can we go to slide 33, please? And in the interest of time, I want to get to our next step. But I'm also interested, any other updates from our other teams before we move on to Carol Nolan and Ann Hemmer talking about early Head Start programs? Anybody else had success or any questions you want to ask anybody? Well, we've been very lucky over the last year to have some excellent presentations from our guest speakers, and you can see the list of things that we've learned about. And so I want to welcome Carol Nolan, who's the Mass Head Start State Collaboration Director, and Ann Hemmer, who's Region 1 State System Specialist for New England Head Start Training and Technical Assistance Network. They're here to talk to us today about their work. And we were saying before that COVID has sort of turned our heads in many ways in a different direction on what these programs are with early Head Start. But they really are here to help us with our patients who and families who suffer from substance use disorder. And so we appreciate you being here. And I think this is going to be super interactive, and we're going to get some polling questions in the beginning too. So thanks to Allie for that. I'll let you go.
Might help if I unmute. Do this all the time. Just to give you a quick presentation, first, Ann and I want to thank Allie and Ron and Callie and Dr. Diop and Dr. Gupta and all the team that we've been working with over the years. We wanted to welcome all of you. We have a couple of questions to ask. Ann and I are going to give you some background information about Head Start and early Head Start, also about eligibility and referrals. I'm going to give you a little bit of data for those of you that really like data about the early Head Start services that we do provide. And then the work that Ann and I have been doing about connecting early Head Start with the medical community, some follow-up initiatives and resources, and then kind of next steps. So Allie, if you want to put up the polling questions. So the first is,
They should be up.
thank you. Do you know what Head Start is and who we serve and who's eligible? And then the second question is, do you know what early Head Start is and who they serve and who's eligible? Because they are two distinct programs, which many people do not know that. And then do you know about any Head Start, early Head Start programs in your community? And I think there was one more question.
Have you ever
Have
worked
you worked with?
Head Start programs?
Yeah.
Right. And then
And these are anonymous. We can't track your answers.
yeah. And there's no judgment involved.
No.
If you haven't done it, it's okay. If you don't
Yeah.
know, it's okay. That's
Yeah.
why we're here. That's why we're here today.
Yeah.
Wow, yeah. So it looks like we got 10 responses. So I'm just going to end the poll now. That way we can move on to the next slide.
Okay.
Is everyone
so-
able to see the results?
Great. So 56% do know about Head Start. Less than half know about early Head Start. Fantastic that more than half of you know about the programs in your community. And if you've worked with any of those programs, so that's what we're here for today, in hoping to make those intentional connections with those programs. And that's what Ann and I hope to do. So Allie, thank you so much. And thank you all for participating in the poll. It helps Ann and I. And Ann will start with the next slide.
So we're just going to give a little context. About half of the folks on the call know about Head Start, but we just want to give you a few facts. So Head Start began first. It was part of the War on Poverty. It started in 1965. All Head Start programs are federally funded. The funds directly go to the local programs. Two of the goals for Head Start is to break the cycle of poverty and to improve school readiness. Head Start is very comprehensive programming. It isn't just a preschool or early education program. We always say that when the enrollment happens, we just don't enroll the child, we enroll the whole family. And Head Start serves kids from 3 to 5 years old in center-based programs, and there are still some home-based programs that the services are provided in the home. The other program is Early Head Start. And Early Head Start was created in 1995. Serves pregnant women and children birth to 3. It is, again, both programs are really 2-generational, but Early Head Start, because the mom can be eligible and enrolled in Head Start during the pregnancy, or after the baby's born, the mom and the child can be enrolled. One of the reasons we wanted to bring this to you today is only a portion of the kids in New England that are eligible for Head Start are actually enrolled in Head Start. So again, the gold standard of the comprehensive services for early childhood program are available. So we want to make sure everybody knows what Early Head Start can provide to your patients and your families. You can do the next one, Allie. So early Head Start eligibility, even folks in Head Start are confused about this. So this is a really important piece. Head Start and Early Head Start are poverty programs. So any family that is in federal poverty, meets the guidelines for federal poverty, is eligible for Head Start. Children birth to 3 and expectant parents are also eligible. Then there's a piece that isn't income eligible, but what we call categorically eligible. So irregardless of income, and this is a very important piece, if child is experiencing homelessness, in foster care, receiving TANF or SSI, irregardless of the family's income, those children are eligible for Early Head Start. So that's a really important piece. Also, set aside slots, 10% of the set aside slots have to be for children with disabilities. So that would be usually a child that's on an IFSP or is with early intervention. So another important piece is that each program develops their own selection criteria, and it comes from their community assessment. So every program has to do a community assessment. Once they see what their community looks like, they develop their selection criteria. So it isn't a first come, first serve program. It's a program that services the children and families that are most in need, again, according to the community needs. And there's a link that Allie's going to make sure you get that on the bottom, that is the Head Start federal poverty guidelines. We can do the next one, Allie. So Early Head Start program and Head Start programs are guided by federal performance standards. And every program is consistently monitored by the federal government to make sure they're adhering to these program standards. So some of the very important standards that look at a child and a mother's health in the Early Head Start program are talked about on this slide. Each newborn and mom gets a visit when they're enrolled in Head Start within 2 to 3 weeks of the birth of the child. And specifically guided by standards, staff need to look at emotional well-being, nurturing, and responsive caregiving, and father engagement during the pregnancy and the early childhood. And some of the services that are provided to a mom and child enrolled in Early Head Start are some of the things listed here. So, and specifically by standard, it talks about the risks of alcohol, drugs, and smoking, prenatal depression, infant care. So there are staff members on the staff, or the Head Start program, Early Head Start program, utilizes community staff members to provide some of these services to the family that is enrolled. We can do the next one. So we have a one-pager that you're going to have access to. Ellie's going to make sure everybody on the call gets the handouts. And this was developed through our association with Penquin by the National Center in DC. And because folks were asking in Massachusetts, well, what is Early Head Start? How do we enroll kids? So this is a one-pager, 2 sides of the page, and it really goes step by step on who would be eligible and how you could make a referral. Also, there's a live link that you'll have the access to that resource from the Early Childhood Learning Knowledge Center, which is ECLKC. That is a website that everyone has access to. Again, it's ECLKC, you can Google it, and there's tons of resources and information. Along with this locator, if you went in that link, you could put your zip code in and you could locate a local Head Start, Early Head Start program in your community. So I think Carol's gonna take the next slides.
Thank you so much, Ann. And I have to tell you that, and Ron knows the history of this, that Dr. Gupta, when Ann and I first started talking to him about Early Head Start being a resource for families before they entered the hospital, and making that connection. And he said, well, don't you have something written about this? And Ann and I said, no. And every program had their own brochure, but there was nothing nationally. And the speed that this took off, that we actually got this document in less than 7 months, is a miracle. For those of you that work, within a hospital setting, you know how long and bureaucracy takes. The federal government, it takes years to get a document. So just the importance of this topic also nationally, that this is now a national resource, any program can use it. Makes Ann and I proud that Dr. Gupta pushed us and said, we want something, and we got it, not just for Massachusetts, but for the whole country. So here's the Massachusetts snapshot. Unfortunately, with COVID, programs were not reporting their data, so I have to use the year previous to that, but it's still approximately the same number. A little over 11,000 received Head Start services in Massachusetts, and about 3,500 children from birth to 3 years old. That also includes 189 enrolled pregnant women. In addition to the education, as Ann talked about, there's also other services. In Massachusetts, there are 30 grantees, and that's my job as the Head Start State Collab Director. I work with all of those grantees. Next slide. So I thought what I would do, because I have access to what's called the Program Information Report, the federal report. And so what I thought I'd do to be helpful to all of you was to pull out some numbers. So who did Early Head Start serve in Massachusetts? So of those families, programs have to report all the different services that they provide. And so for almost 3,000 families, sadly to say, almost a third had to receive emergency or crisis intervention. 481 families received mental health, 413 needed services in response to child abuse or neglect, 511 experienced homelessness, and Ann and I have been very active with the Homeless Educational Stability Committee with Department of Elementary and Secondary Ed. 100, and again, this is what's reported. We always know that there's more that's not reported, but this is what's actually reported. And 23 of those families actually received services for substance abuse treatment. So we wonder where the gap is. If people wanted to know about prevention, but then only 23 families actually received the services, was it the services that weren't available, or was it doing the actual groundwork and resources to connect families? The other big thing is that of the pregnant women, 118 received services for substance abuse prevention. And again, only 34 actually received treatment. So there's a gap there. And so we just wanted to show you that even within our own program, we're serving these families. That's why Ann and I have made this a priority. We're serving these families, but are we actually connecting them to the treatment and to the services that they need? Next slide. And we put this in because in many hospitals, parents that are dealing with substance misuse are often referred, their children are often referred to early intervention. And we work closely with early intervention, but we want you to know that early intervention isn't always just the only answer. And so Early Head Start can be that link. So they can get early intervention and early Head Start. And as you see in the numbers, almost a third of the children who are enrolled in Early Head Start have IFSP plans, and that there 819 were eligible to receive those services and then determined eligible to receive them during the enrollment year. So many times kids are screened in or screened out. But Ann and I know that this has been a statistic that Dr. Gupta has shared about women having babies and being referred to early intervention, and then what happens after 3 months, 6 months, and a year, and many of them drop out. And so Ann and I have often talked, and we've shared some of this presentation at Penguin Summits, that many see that maybe as a punitive thing, and we want Early Head Start and early intervention to be seen as a supportive action and not as a punitive action. So coupled together, that may work. Next. And then this is just some of the ways. I'm not going to read everything, but Ann and I have been invited to share our information at conferences, as well as Dr. Gupta has been asked to do. He spoke at our opioid summit. And we've also had, been just doing this partnership and been doing this dance and really trying to, it's not a, it hasn't been an intentional connection. We want to make it an intentional connection with the medical community. Next. And also that early Head Start, if you see under the family support plan, and I saw that was one of your webinars that you had earlier this year, Early Head Start is listed as one of the support services on the family support plan. So we're there, which we're thrilled. And so that, you know, you can see this can be very useful for your clients and for the families and parents that you work with in your hospitals. Next. And then some of the recent initiatives that we've had. So Ann talked about the one pager. We did a webinar last year for Wave 1. And so now we're back again working with all of you. There's been a lot of videos and additional resources on our ECLKC, and we're going to give you that link. And also the National Center of the Office of Head Start has been working with Sesame Street. And they just had an incredible webinar if you have not seen it. And I love Elmo. And they how to talk with children about parental substance use. And there's resources, and it's amazing. Sesame Street is just over the top anyway, and how they've really done so much research and how best to approach children who say, you know, well, my mommy went away for 8 weeks and I'm living with my grandmother, and it's just well done. So anyway, next. I just recently finished this with Ann. So we had this statewide cross-agency initiative of training people in something that you had mentioned, Ron, too, just about people's knowledge. People don't even know like what an opiate, they just say, oh, that's heroin. Like understanding what that is, understanding the stages of recovery, understanding that people who are in recovery for 2 or 3 years, quote, aren't out of the water. You know, and the support that we need to give them in those stages, and then the things that we can do in programs to support those families. So we just finished a free cross-agency training where we had folks from housing, we had folks from shelters, we have recovery coaches. It was wonderful. And it was a day-long virtual training. And then we just literally last week finished a follow-up train the trainer so that people can go back to their programs and share this information. It was all free. It was done with my Head Start, with my federal funds. So we're really proud about that we're still keeping the information and the education. As Ron said, every year it changes. And so we want people to know that just because a mom is on methadone doesn't mean, quote, that she still has a problem, you know, with addiction. People say, oh, why is she doing that? She's hurting her baby. Like, we want people to understand and know the newest. Next. Ann's going to talk a little bit about the resources that we can share with all of you.
Again, if you don't know this website, it's accessible to all. American Academy of Pediatrics contributes. A lot of the universities contribute. So there's a plethora of resources around early education, mental health, along with substance and other, a lot of updated substance resources, particularly about working with families, because that's what we do in Head Start. Mm-hmm. The second bullet, the resource, is a new resource that came out of a request from the people in the field, and it will go back to trying to address that statistic that Carol showed, that we had that many people that said they wanted information, but there was so many less percentage of those folks getting services. Some of our staff said, how do we work with these folks? We're not experts in the field. So a couple things that we've tried to make sure happened was, one, we've tried to make sure all over New England that we partner Head Start staffs with local folks in the community that are doing the work around substance misuse. And that's been fairly successful. The other thing we did was ask that this tool be developed, and what it is a screening tool. It is not an assessment. It is not a diagnostic tool. It is merely a screening tool for folks in the field with language and with strategies of how to speak with families.
Mhm.
To try to identify or have families self-identify. Again, our staff, a lot of our staff are not experts in the field.
Mhm.
Next one, Natalie. So we're not going to read this. We are trying to, again, as Carol said, continue to partner with Pinquin, continue to develop resources and trainings for our staff in Massachusetts and in New England, and continue to partner with folks that are doing the work and make sure that Head Starts know that they're not out there alone and that they don't have to develop all these things, that these resources are available, and make sure that we connect early Head Start and Head Start staff to the available resources.
Mhm.
Wow.
And Carol, you can wind it up.
Yeah. We a couple of things that Callie, when we were working with her about resources. So I took updated information on our contact list. So you'll have a document that shows you all the Head Start programs in Massachusetts that also offer early Head Start, or some of them that are just early Head Start. So you'll have that contact list with the program director's name, phone number, and email address, but you can also use the locator. We also gave you all a copy of this PDF, as well as the communities that are served, so that you, and that was something that we mapped out when we were doing work with homeless families. We wanted to know if there was a homeless family in the Drake Public School, what Head Start and early Head Start would they be connected to? So same with you in the hospitals. So thinking about when you look at that list, you may not know that Triumph serves Brockton as well as serves other communities, just because they're located. Like if a program's located in Lawrence, but they may serve 6 other communities. So we wanted you all to know that information as well. You have our email addresses if you have specific questions for Ann and I. And I said earlier before the webinar started that Ann and I are hoping, now that COVID and Massachusetts is making really good progress, that we can continue to do the work that we started and connecting early Head Start and Head Start programs to your hospitals, and making sure that they know about your hospitals and your hospitals know about them. And then it's up to individual programs and hospitals to make whatever connections that they want. Some hospitals are on the health advisory with Head Start. Some Head Start folks work with the hospital staff, so it can be reciprocal as well. But there's lots of ways that we can connect our work and connect the staff. And more importantly, our goal is, your goal is to offer as many supports and services to the families that we work with, especially those that are impacted by substance misuse. So, and we did it all in time. If there's any questions.
Warp speed.
Questions? Yeah. I'm just so impressed with what you guys have been doing over the last couple of years, and I'll make a plug for the summit and our resource packet that we'll be putting that information there as well for people.
Yeah.
It's impressive how the numbers between early Head Start and Head Start are so different. I mean, there's no way those families are doing fine until the child is 3.
Right.
And then they need Head Start. So yes, this is definitely important work to help that linkage.
And Ron, one of the trends, and something that Ann had mentioned earlier, and we're seeing it now since the pandemic, is that, the demand for infant and toddler care, as opposed to preschool care, with some of the universal pre-K programs and some of the public school programs, that in many Head Start programs, they're getting more demand from families wanting to start their children younger. And so there's been, that assessment. In Massachusetts, we're serving, I think, 4% of the eligible children in early Head Start. And it's not from not wanting to serve them. We don't have enough slots. We don't have enough funding.
Yeah.
The funding is really imbalanced, but that was because Head Start started in 65 with a lot of money. Early Head Start came along later when people started realizing It's really good to start early.
Hmm.
It's really even better if we start when they're pregnant, right, in utero.
Right. Yep.
So I think that we're going to see a shift and a change, and especially since the pandemic, of many preschool programs, not Head Start, but many preschool programs that have shut down. That just couldn't sustain, and what that means about serving infants and toddlers. The other positive news that I wanted to share with all of you is the federal government has seen Early Head Start as a national model and has given money through a federal grant, what's called Early Head Start Childcare Partnerships, right? To raise the quality level of family childcare and childcare to the levels of Head Start. And 3 of our grantees in Massachusetts recently, over the past 2 years, have received that, which means additional infant and toddler slots. So one is on the Cape. Actually, 2 of them are South Shore and on the Cape. And ABCD in Boston also received that money as well. So we are serving more infants and toddlers as a result of that additional federal money, and we hope that that's going to be the trend. It would be my dream that all childcare programs are all following the Early Head Start standards, and every family gets comprehensive services, not just because you're poor or homeless, or have your child has a disability. That every family should get these comprehensive services. That's my dream. But
and I just want to add that anecdotally, I'm a registered dietitian, and my career started in hospitals. So I worked for 17 years in hospitals before I met Head Start. And I do have to say, once I met Head Start, I was a much better clinician after I met Head Start, because I could really see where the families were at and learned so much from Head Start. So I didn't start in Head Start, and I was a late comer to the Head Start world, but the comprehensive servicing and what you learn about family engagement and involvement, like I said, just made me better at what I did.
And the final touch is that the Office of Head Start Director, the National Office of Head Start Director, who's appointed directly by the president, is a Head Start graduate.
Oh, I'm a Head Start kid.
Yeah.
Wow.
Yeah.
There's a story.
Pretty amazing. Yeah.
Yeah. Wow. That's success.
I know.
Yeah. So Linda Burke is giving a shout out here.
Yeah. That's
wanting to serve all populations. Yeah. All right. Well,
thank you.
Thank you for what you do, and thank you for this presentation, and putting it up in front of all of our eyes again, and into our heads. So thank you. Next slide, please. So Kaylee just does want to say goodbye. I think she's super sad that she's not going to say goodbye to you personally. But just so you know, we're always around to support what people are doing in terms of opiate use disorder, substance use disorder, as well as the other quality improvement and bundle work people are doing. We are beginning to collect information, data through the Betsy Lehman Center REDCap database, and she will be reaching out to you to sign an MOU so that we can get some information and just see what's going on around statewide, see where there might be some areas to help out and see where some of our strengths lie. So we also recommend that you apply for the Speak Up training. These slides will be available and all that information is there. Implicit and explicit bias training is just so key to making our care even better for all of our families. And thank you again for all you do. Got a great little caption there at the bottom. This is a little sad for me because this is 2.5 years now of doing these webinars through Wave 1 and Wave 2. So I thank our entire team. Hopefully they'll watch this webinar. Thanks to Allie, thanks to Kaylee, thanks to Brianna Sacheret, who was with us previously, who's now in medical school down in Texas. So it's the project managers and coordinators who actually get everything to happen. So thank you for your work. Thank you guys for showing up. Spread the word. If people have questions, they can always look back at these series on tape through the website. And we really appreciate everybody's work out there. Hopefully we'll see you at the summit. Have a great day and be safe, be well.
Thank
Bye-bye.
you, Ron. Thank
Yeah.
you, Ellie. Thank you,
Yeah.
Ann.
Yeah, it's awesome. Thanks, guys. Stay out of trouble.